What is antimicrobial resistance? Antimicrobial resistance is the ability a bacterium gains that allows it to evade the effects of an antimicrobial. Antimicrobial susceptibility testing, or AST, helps us to find out whether a bacterium has developed resistance to an antibiotic. When should we perform AST? AST is used to guide selection of systemic antibiotics for treatment of bacterial infections and is especially useful when there is a concern for antibiotic-resistant infections. Risk factors for antimicrobial resistance include antibiotic administration in the last 3 to 6 months, recent hospitalization, and recurrent infections. When is AST not useful? For some bacteria, laboratories can tell you what type of bacteria is present, but cannot tell you which antibiotics are going to be effective against the bacteria. This includes GI pathogens like Salmonella. AST is also not useful to make topical antibiotic choices. This is because AST is based on concentrations of antibiotics in the plasma, while higher concentrations of drugs can occur when they are used topically. For example, Pseudomonas aeruginosa cultured from the ear canal might be resistant to an antibiotic on an AST panel, but the concentration of antibiotic with topical application far exceeds the highest concentration of antibiotic tested on the AST. This means that AST panels can't predict whether a topical antibiotic will be able to treat the infection. Sometimes high concentrations of antibiotics in topical preparations can overcome the resistance seen at lower systemic antibiotic concentrations. What do we need to know about sample collection and submission? For quality results, provide good quality samples. Minimize contaminants by using cystocentesis for urine samples. If that is not possible, like for a wiggly Labrador retriever, a clean midstream urine sample collected by veterinary staff in the clinic is okay. Just don't submit urine from an owner-collected sample. For wound sample collection, clean, debride, and lavage wounds before sampling to avoid culturing surface contaminants. Remember, don't culture what ends up in the trash. Culture what is left behind in the wound. That's what you want to treat. Tell the lab about patient signalment, site of infection, sample source, and medical history so that the lab can provide appropriate interpretation of AST results. Not identifying the disease process, for example that you suspect pyelonephritis and not a lower urinary tract infection, may result in incorrect susceptibility testing by the lab, inappropriate antibiotic selection, and ultimately treatment failure. Unsure what to submit or what information the lab needs? Just ask the laboratory. How do we interpret AST results? First, some definitions. MIC refers to the minimum inhibitory concentration. This is the concentration of an antibiotic needed to inhibit growth of the bacteria from your patient sample. Breakpoint is the concentration that's expected to inhibit bacterial growth if there's no acquired resistance present. Your sample's MIC is compared to the breakpoint to determine whether bacteria from your patient is susceptible or resistant to an antibiotic. When MICs are below the breakpoint, the lab reports the bacterium is susceptible to the antibiotic. The comparison of breakpoint and MIC happens for each antibiotic tested. Time to bust a common myth. Don't compare MICs between antibiotics. We don't use the same milligram per kilogram dose for all antibiotics, so of course the concentrations of drug in the serum are different for different drugs. AST panels test concentrations of drugs achievable in the body after oral or parenteral administration. This means that MICs should only be compared to the breakpoint of that antibiotic. The labs do this for you, but you never see the breakpoint values on your report. This can be confusing. What is important is the susceptibility interpretation the lab made based on comparing the MIC to the breakpoint. S means the bacteria is susceptible to the antibiotic. R means the bacteria is resistant to the antibiotic. Some labs report I, which means that there is intermediate susceptibility. Use of these drugs should be done with care and will likely require dose and/or frequency adjustments. Some other important notes. When a bacterium is deemed to be susceptible to an antibiotic, using skin and soft tissue breakpoints, or SST, which is based on plasma drug concentrations, the antibiotic should be appropriate to use for infections in tissues such as skin, bone, synovial fluids, and internal organs. However, there are sites that have barriers to drug diffusion, like the central nervous system, eye, intracellular sites, prostate, and mammary glands. For these sites, additional consideration for drug selection should include whether or not the drug can get to the site of infection. Antibiotics excreted by the kidney can reach concentrations in urine much higher than in plasma, so different lower urinary breakpoints are applied. Bacteria may be resistant to drugs in tissue sites, but susceptible to the same drug in the urine. For example, amoxicillin can treat E. coli in the lower urinary tract, but not in the kidney. Knowing some basic facts about AST can improve the quality of results and confidence in antibiotic prescribing. For more help on making antibiotic selections, check out the clinical resources at www.arsi.umn.edu.